Good morning. This is the BLAINESWORLD podcast that can be found each week on Facebook, YouTube, and LinkedIn. You can also listen on Spotify or Apple Podcasts. You get more information and listen to previous shows on our website, www.blainesworld.net. I'm your host, Blaine Greenfield, and here in my Zoom studio in lovely Fairview, North Carolina. And each week we focus on positive news and information about people and organizations in both Western North Carolina and throughout the country. And toward that end, it's my pleasure to introduce my two guests today, and they are Dr. Ellen Kaczmarek. I think I have it close enough. I got it, great. And also Dr. Marsha, last name is again? Marsha Fretwell. Thank you. And thanks, by the way, to you both for joining me today. You can wave to all your friends and friends who are watching this. So if you're watching this, you can see that's Dr. Ellen and that's Dr. Marsha. You can wave to everybody if you're watching. And I should mention that Dr. Kaczmarek was born and raised in the Northeast and said she moved here to Asheville as soon as she could. I like that. She practiced geriatric medicine for over 30 years in a variety of settings and developed a passion for helping everyone acquire the golden ticket of Medicare. That's cool for everyone. I love that idea. And I'm at a disadvantage, Dr. Fretwell. If you could help me a little bit in terms of your background, I'll give you another like 10 or 15 minutes. Can you summarize it? Okay. If you would.
Well, I'm actually from Virginia.
Okay.
But I lived in Wilmington for the last 20 years before I moved to Asheville. And in those 20 years, I had a private practice that was predominantly geriatric patients or people over the age of 65. And I got interested in HealthCare for All because I found that I was enjoying my practice because I didn't have to worry about people having coverage for the services. So I could actually focus on caring for them, and I didn't have to worry about whether or not they had health insurance. And so when Ellen started HealthCare for All Western North Carolina, I joined up because I really do think we need to move to coverage and accessibility for everybody for healthcare.
And don't you think that's, such a great thing that we not only need in North Carolina, we need it throughout the country, that,
absolutely.
Just can you believe that people can't get health care, or can't afford it, or that's don't right. I guess what's even worse, they don't get help, they don't seek health care because they can't afford it, what a shame. And let me then ask you both individually, because I'm kind of interested in the response, is that as a child growing up, both of you, I guess ask Dr. Ellen this first, did you always know you wanted to be a doctor?
Probably from the time I was an early teen, I would say I did. I worked in the hospital after high school, in the afternoons and on weekends. And then when I went to college, I also worked in the hospital doing EKGs at the time. Wow. The technology's changed, just saying. But yeah.
And so you were probably blessed, I guess, in the sense that when you were a young woman growing up, that people were actually encouraging you or not discouraging you from going into medicine at the time?
Oh, I was really encouraged. Yeah. So yeah, I was, this is early 70s when I would have been in college. So
me too. Yeah.
Yeah.
And no, what I'm saying, what's so cool about this is that so many other women I've met and come across that they'd be encouraged, if anything, to be a nurse. That was the
right
place for a woman to enter medicine. Mm-hmm. And so you were encouraged. What a great, thing that was. So how did you decide to specialize in geriatrics?
I had two wonderful grandmothers. So I was very comfortable with that age group. And I realized I did 3 years, I owed the government 3 years of service after I finished medical school and my residency. So I was working in a federally qualified health center in St. Louis, Missouri, and I realized that I really preferred dealing with older people. So from there, I finished my 3-year term and moved into working in a nursing home for a period of time, and ultimately went to work for a small hospital as a geriatrician for them. And in the meantime, geriatrics, Marsha can tell you more about this, but geriatrics is a fairly young subspecialty of medicine. So when I finally came into it, they still would allow you to grandmother in by qualifying with an exam, which is what I did.
And so when you were in the practice or entering the practice, it's probably then you were younger than all your patients, that.
Oh, yeah, yeah.
Let me ask you this, because even my wife and I still have this attitude, and it's perhaps a poor one, but when we see somebody younger now, or a younger doctor, which is just about everybody, my wife will say she can't believe that person is a doctor. It looks like a kid 21 years of age. I guess, did you have that when you first began, that people couldn't believe you were a doctor?
No, I don't remember that. I mean,
Well,
it's all in the way you present yourself and carry yourself.
I guess maybe they never told you, that they couldn't believe how young,
That could be.
young you were.
Well, the thing I always knew is that I could retire when I got to be my patient's age, which is what I did. So.
Okay. And Marsha, I'll ask you the same kinds of questions. So in terms of, when did you decide you wanted to become a doctor?
Well, I'm, I guess, a full decade older than Ellen is. So at that point in time, there were very few women.
Right.
We were not encouraged. And I went off to college to actually be, I think, a medical technologist. And then I realized I wasn't going to be having a full year college experience. I said, okay, I'll just take my BS in biology. There was one woman in my college who was thinking about becoming a physician. And I said, wow, that's really interesting. And I actually took an aptitude test in the 7th grade,
I remember.
and they aimed me right into healthcare. And I also worked in a hospital from the age of 14 to 18. I did all the EKGs, I drew blood, I did everything. So, but what really, after I graduated, I went up north to Boston and worked in a research laboratory. And it sort of became clear, things were breaking. It was 1968. Everything was erupting and being different. And I worked with a group of physicians, and one day I sort of looked up and I said, I think I can do this. And so I set about getting myself into medical school. But I graduated, there were 3 women and 100 men. And in my internship class, there were 3 women. And so it was an interesting experience to do it. And I loved it. It was perfect for me as a career. I'm kind of a very curious person. So learning all of the science as well as caring for other people just was a perfect match. I think I got into geriatrics to help me come to terms with people dying. I had young patients dying, and it was devastating. I just couldn't make it work. And I found that older people actually helped me come to terms with what was happening to them. And that was my sense of comfort about taking care of older people.
Let me ask you this question. Let me ask you this question too, in terms of how you define geriatrics. And I guess I should know it, but I don't. In other words, is there a way to, well, I'll ask you, how do you define it?
Well, reimbursement wise, if you're over 65, you are eligible to enroll in Medicare, which covers all your healthcare costs. But the true practice of it has to do with how well that person is functioning. So we had many patients who were under 65 who had had strokes or had had a cancer, brain tumor, or some other medical illness, who just had a very complex collection of medical diagnoses and physical disabilities or mental disabilities. And I think we geriatricians became the ultimate generalist for people who were losing function as they grew older.
Now, let me ask you both, I guess, for advice, if you can, in terms of.
Oh, wait a minute, time out.
Okay, but I won't quote you. But anyway, if somebody's listening in the Asheville area or anywhere else, when you seek a physician, say at the age of 65 or whatever age, do you seek a geriatric specialist, or do you seek a regular doctor? How do you find you two folks when you were practicing?
One of the problems right now is that there is a real paucity of trained geriatricians, not just in this area, but also in the United States. So, searching for them will yield maybe 2 or 3 people in this immediate area who are certified as geriatricians. Can other physicians take excellent care of older patients? Absolutely. I think that my only, what I would recommend for somebody who's over 65 is that they lean more toward an internal medicine physician, because they tend to do adult medicine only rather than being as broad based as the family practitioners. But that's me. That's me.
Yeah, it's funny.
Yeah, it's actually a rather sad story. I was the first fellow in geriatric medicine at the University of Washington in Seattle. And I was at the beginning of an era we were going to saturate the medical schools, and we were going to send practitioners out. And because everybody saw this, what was coming down the road was the aging of America. And it didn't work. It did not work. And I guess it's a complex reason, but I think it's because in our system, reimbursement for spending time and talking and struggling with issues, complex issues that are social as well as medical, as well as cognitive and all of that, it doesn't pay. Okay. It pays to do procedures predominantly. And I learned that actually as I was training up doctors, because I could talk a lot of people into going into geriatric medicine, very charismatic about it. But then I realized that they wouldn't be able to earn a living.
Which is what brings us back to our healthcare for all issue, because one of the big hallmarks of every other industrialized nation in the world is that they do have a single payer system, and they focus on primary care. So we were considered primary care physicians for older patients. So that's so the reimbursement mechanism, or the reimbursement schemes for the subspecialists who do procedures, et cetera, right now in this country is widely skewed toward reimbursing them more heavily than it is for the people who do the primary care medicine. So, and that's one of the reasons that in this country, primary care medicine is not the internists, the family practitioners, the people who practice primary care, geriatrics, et cetera. We're just not paid very well.
Well, it's so perfect timing to have you both on, and I'll send this to you off the air. But I just ran something in Facebook, I think it was a couple of days ago, talking about somebody needing medical help. And so talked about 2 cases. First person goes in and has a bad hip, needs a hip replacement, and is told, well, it'll be 6 months before they can get, 6 weeks before they get the x-ray. It takes another week to get the x-ray analyzed. And if they need the replacement for the hip, that'll be 6 months down the road. You know, contrast that, they describe a second case, same thing, seen that day, x-ray, get operated next day, and the second patient is a dog, you know, and it's, but I'll send it to you both. But isn't that true? What a sad thing that if you need medical help, it's becoming, Marsha was saying, in this area, but everywhere, so difficult to even get any medical help. And it's, you know, it's a problem.
It's unweaving.
Yeah.
Yes, it is.
And the sad thing is not getting better. You know, it's going to get worse. And so talk then about I love the concept, HealthCare For All WNC. I believe you were, Ellen, one of the co-founders of that organization. When did that start?
Correct.
When did that start?
That started in 2017. We were initially members of the of Indivisible, and there were a group of us that came together at this big meeting that was held down at Pack Library for Indivisible, and we broke up into different groupings. And I ended up in the healthcare grouping, and then that was so large that we had to subdivide it. These were all categories that we were pretty sure were going to be issues that were not being tended to by the administration that came in as of the 2016 election. So, so Healthcare for All has been a passion of mine for a long time, and we evolved into this group. We're an affiliate of Physicians for a National Health Program, and that was established in the early 1990s and has been continuing to beat the drum for a single payer health plan in the United States. So there we
Can
are.
you talk a little bit about that concept? Because when you mention it, some people get all sorts of upset by it. The
Right.
term, and forgetting politics for a second, but single payer, that's socialism. That's radical. How can you have this in this great country of ours?
So
What's that all about?
I'll do the short version, and Marsha's going to do the longer version. So just so people know, I think it's really important. HealthCare for All is what we call our organization, but it's also known as a single payer plan. It's
Okay.
known as Medicare for All. Some people call it universal health care. It's a national health program, but it all means the same thing. And here's Marsha to explain it to you.
Okay, take it away, Marsha.
Essentially, it means that we would have one public payer system and a private provider system. Right now, we have tremendous numbers of intervening insurance companies between the payers and the providers. And what's happened over my 40 years in practice is those for-profit insurance companies in between have actually taken more and more control over the whole structure and practice of. My reason for going into primary care was I was told that I would only have 15 minutes to see each of my elderly patients. And I said, I can't get her on the table in 15 minutes, much less examine her and have a conversation with her husband and her daughter. And, it's really complicated. So that's what actually drove me into private practice was, in fact, the insurance companies were already saying efficiency, efficiency, efficiency. And basically where we've ended up is profits are more important than people. But coming back, a single payer would be a public paying system that would cover everybody in the country. The people delivering the care would not work for the government though, okay? Right. They would be in private practice, which I was in my practice, and I basically submitted a bill to Medicare and they electronically paid that bill. And I was able to run a really small office because I didn't have to deal with for-profit insurance companies because all of my patients had coverage. And I only had 2 women in the office, and many of these internal medicine offices will have 15 women doing nothing. Submitting bills to insurance companies and fighting for coverage. Okay.
So the socialized medicine that you had mentioned before, in this country, the VA is a perfect example of socialized medicine because the government owns the means of, they're the payer to the people who provide the care, and they also employ the physicians, the nurses, etc. And they own the hospital.
And they own the hospitals.
Right. So everything is wrapped up into one ball. And that's not what we're talking about.
So, and that's an interesting question, is if we do move to one system for everybody, would that then incorporate the VA system into,
right?
And it would,
right?
Because we would bring it all into one system.
Right. The other thing, just listen to you folks, and I appreciate the explanation, is that the other problem, I guess, in this country is there are all sorts of different ways people are paying for health insurance. So I was blessed. I was a teacher and had a great healthcare system, and I got reimbursed, and I was there for a long time. But if you're not with an employer who pays for healthcare, who pays for it? And then it's even worse that what if you're not employed or you're unemployed? Who pays for healthcare? And does that say that you can't get healthcare? And that's unfortunately what we have in this country.
That's right. And one thing happening with young people, and my son brought this to my attention, he switched jobs.
Right.
And now he's given X amount of dollars to buy health insurance every month. In the previous job, it was like they were running in and out of different for-profit healthcare
Right.
You know, they kept
Right.
changing, they
Right.
kept changing the company that they were
Right.
negotiating with because the prices kept changing and everything. And he's so grateful. He's 43. And he says, you know, I am so grateful that I have an insurance and it's all coming from one person.
Well, the worst thing too, Marsha, in your son's example too, is that if somebody switches jobs, then they sometimes are told, and I've seen this as well,
right.
you can't
That's
get it for what, a month,
right.
6 months, a year.
That's
Yeah.
right.
And so what do you do? What do you do in that case to get, you need to see a doctor, you have to pay for it out of your pocket,
That's right.
but it just never, there's no solution to that. I mean,
Well, healthcare for all.
Yeah, well-
Guys, okay, so when you're born, this is the way it would work, just so you know. When you're born, you get your health card.
Right.
When you die, your health card is retired. You can move to any state. You can move anywhere. You don't have, it's not tied to your employer. It's yours. It's kind of like having your social security card.
Yeah.
So that's the whole lot difference. So entrepreneurship, I mean, Asheville is a great example of a place that people come to start their own little businesses, etc. You know, you would be covered by healthcare. You wouldn't have to stay with an employer just to keep your healthcare.
You know, and just listening to you, not that your intent is to get me annoyed, but I'm kind of getting annoyed, not with the two of you, but just, you know, the process. You just explain it like you're explaining it. How could you be opposed to it? You know, well, explain one other thing to me, since we're on the topic. What was it in North Carolina? Was the battle, still is, the concept, what was it, Medicare? Was it Medicare expansion?
Medicaid.
Medicare expansion, yeah. But the same principle though, there would be no healthcare for all. There'd be no, right, Medicare and Medicaid.
That's exactly right.
Right.
You're
Yeah.
exactly right.
So
It would be simplified.
right. But the thing back to that one, you're right, Medicaid. But how could you be opposed to that? You know, it's just inhumane to not want coverage for everybody, what state they live in. So let's talk about this then in terms of, it's a great concept. We're not talking like Bernie Sanders. We're not talking whoever you name, a single payer. I don't understand, why did it get such a bad rap from some people?
You know, first of all, some people are under the impression that it's a what's the word?
Socialist?
I forget my words too. An entitlement. You know, that it falls because people didn't earn it, quote unquote, they shouldn't get it. You know, that's what I believe is a rising tide lifts all boats. So, you know, by having this, you allow people then to perform at the top of their game, or at least it's one more thing that allows them. It lends to equality for everybody, or at least a sense of equity for people. So people who don't think like that, you know, may be opposed to it. The other question is, how does it get paid for?
Well, that was the next question. In other words,
Let me just jump in because before we get that, because it's about the money. I think it's the money. People who are making millions, billions of dollars off of medications and and the illnesses of other people.
Right.
And I can tell you, since 1970, the cost of our healthcare system has gone right up, okay? And health outcomes have gone right down.
Sure.
And there has never been, and there are lobbyists for the major corporations, and both Democrats and Republicans are receiving huge amounts of money from the lobbyists to keep things just as they are. And not blaming either side, okay? I'm just saying there's so much money running. You know, our hospital, it's true. Made a profit in the middle of COVID.
Right.
Okay.
Yeah.
Now tell me about that.
Yeah, by the way,
dying because they had no coverage.
Right. And don't get me on that too, but that's a whole nother show, you know, I'd love to do sometime.
Thank you. Yes, it is.
No, when I moved to Dr. Ellen, when I moved to Asheville, one of the great reasons was because it had the great hospital, you know, had this outstanding reputation.
Absolutely.
And all of a sudden, it went, you know, not all of a sudden, but over a period of time, from a great hospital, a great reputation, to one that doesn't have the same reputation. What a shame, you know. And back to, unfortunately, back to money. And so let's segue that into the question I was going to ask you then. So let's say you even agree with the concept. I love it. You've convinced me. People listening to it. Coverage for all. How do we pay for it?
Okay, so this is a fairly simple formula.
Okay.
66% of it will be paid for by the monies that are already there for Medicare and Medicaid. That's federal monies that are already there. And oh, by the way, Medicare, you've paid into that.
Right,
That's a trust, that's a public trust. Okay. So then the other two would be paid, the other
2/3, 1/3.
34%, right, 1/3 would be paid for by payroll taxes and so the employers would be paying and you would be paying a little bit more in your taxes every year. However, let me go back to the payroll tax first, because employers will be shouting and screaming. But what happens now is that every year the employer has to use lots of time to look for a plan that will cover their
Right.
employees. And particularly if you have an employee who happens to be a high utilizer, somebody who's got like, some terrible thing going on, that skews everything with how the employer has to pay for the healthcare for the whole group. So, so that cost is never a fixed cost. It escalates. Yes,
It has gone like
Right.
that every year.
so what we're looking at is if there was a payroll tax that was fairly flat, then they would know they could factor it into their budget every year and they wouldn't have to spin their wheels trying to do all this research every single year and trying to decide if you were going to get a higher and higher deductible plan every year.
And the worst thing, what you were saying is, because I was on the other end, I was in a union. You don't have that in North Carolina. I was always battling with the administration. But what's the sad thing about what you're saying is that every year, then they were just looking to cut and cut
Right.
What we were getting. And
Right.
like you said, the couple people skewed it, made it impossible. I mean, the benefits kept getting worse and worse. So instead of getting better, it was all the time, it was a battle, every year.
Absolutely.
We were negotiating. So keep going though about paying for this, then I guess.
Yeah, so now you understand why the payroll tax would be actually an easier thing for people
Sure.
who are employers.
It's far less money.
Yeah, and then if you're going.
Let me back up the one thing though. So I got you, accepting that that's if the employer offers health insurance. But what about like a lot of mom and pop operations?
It wouldn't be an option.
Okay.
Everybody who is an employer would have to pay the payroll tax.
Gotcha. Okay. So I'm sorry, I cut you off. Yeah.
Yeah, no, you're fine. So now we're getting to the patients, quote unquote, and individuals who would be paying taxes. So again, you're going to be paying a fixed amount in your taxes on a yearly basis, but you're not paying, but it's a lot less than paying the premiums that you're paying, the deductibles that you're paying, the out-of-pocket expenses that you're paying, and all the miscellaneous little expenses that add up to healthcare. Right now in this country, per capita, it's over $12,000 a person per year just for their healthcare stuff.
That's twice as much as any other industrialized country.
And that's also the scary thing about what you're saying. That's for people who are taking advantage of the healthcare system. Unfortunately, there are a lot of people who should be, and they just don't get treated or get covered.
So we were discussing that a little while ago. So, when people say, oh, but there's going to be a rationing system, we're sure. Right now, the harshest rationing possible is the fact that people can't afford to go to access healthcare. So they get sicker and sicker and die without any attention to it.
Talk about how you both being physicians, talk about how doctors would perceive this, or how would they feel about this?
That's an excellent question. And the first thing I'd like to introduce, though, is a concept that doctors right now, and I think other practitioners, nurses, are suffering under something that I call moral injury. Having the privilege of becoming a physician and using your brain power and your heart to actually have a job where you're caring for other people and you're supporting them. It was the greatest profession that I could ever imagine. I was the happiest doctor in the world. And we now know that doctors are not very happy. Now, I am not naive enough to think that they will be lining up saying, well, I'm going to take a cut in my salary to do this. But I think it's going to be a trade-off where what they do on a daily basis will be so much more meaningful than what they're doing at this point in time, and so much less stressful than how they're having to practice at this point in time. But people have done the analysis of where the shifts in money, and some physicians who are being paid very highly at this point in time probably will see their salaries come down. Primary care practitioners, psychiatrists will probably see their salaries actually go up. Pediatricians are another group, geriatricians are another group. So there's going to be a lot of shifting going on. But I guess I'm counting actually that they are going to be so excited about escaping the moral injury of practicing in the current system. I did the analysis, that was almost 8 years ago, and something like 42% of physicians in North Carolina were lined up to be retiring.
Right.
Because they just didn't want to work in this environment anymore. So it's going to be a complex transition. Let's go to other people. People have asked us, well, what about all those poor women who are working in the insurance industry? Well, they have a 6-month rate anyway. And the truth of it is, if we start covering everybody, we're going to need more healthcare workers. And I'm here to say, with no excuses, it's a blessing to be a healthcare worker compared to being an insurance paper pusher. And anyway, that's my comments.
No, I love what you just said. And I guess the other answer to those folks is that, well, you'll also have coverage your entire life. You won't have to worry about I mean, everything. Because let's talk about that concept too, that with coverage because of insurance restrictions, you can only get so much coverage, and then you can't get treatment, I guess, when you want it, or see doctors when you want it. And by the way, do you think this will help get actually more doctors in the area? Because one of the problems in Asheville, but it's throughout the country, is we don't have enough doctors now. We don't have enough geriatric doctors. You name the kind. Do you think that'll open up? It'll make it easier to find a doctor?
I think that there's a couple of things that have to happen. The legislation also needs to include looking at the cost for medical schools, because that's actually one of the reasons that a number of physicians kind of gets skewed into higher paying subspecialties, because they've got such enormous debt when they get out of schools. So I do believe that there will be more primary care physicians. I think the role for nurse practitioners and physician's assistants will probably that will see a change a little bit in how they're utilized as well. It's going to take educating the patient population about what medical care really can do for you and how it can help you. It's going to be health care and not illness care. And that's one of the other paradigms that needs to shift in this country, is to really stop thinking about everything as I go to the doctor because I'm sick. I go to the doctor to help me stay well.
And prevention is not reimbursed very well.
Okay.
Because that requires sitting down, talking to someone, developing a relationship of trust. And that doesn't happen overnight. That's called a relationship. And the truth of it is, physicians haven't had much time to have relationships with their patients over the last 30 years.
But like you were saying too, and I'm used to it now, but any visit is typically a 15-minute visit,
Right.
And if I need more time, I've had this the other day, she's told she has to make another appointment, if you can even get the other appointment, it's a real problem. Talk about where we go from here. So I think, and I want to thank you both. I think I have a better understanding of this, but if folks want to get behind it or find out more for HealthCare for all WNC, even though it should be healthcare for the whole country, where do they go and what should they be doing to find out more?
Well, there are a couple of different, we have a website. It's this is all one kind of HealthCare For All WNC.org. It's all, glommed together there. We do have a Facebook account. Healthcare is health, and then capital, and then elided, capital CARE, right onto health for all WNC. So capital HEALTH, no space, capital CARE for all WNC. That's Facebook. We do have an Instagram account as well. I would say the other thing to look at is Physicians for a National Health Program, their website, PNHP.org, because it gives you the national picture of what's going on in the United States. Marsha and I have kind of this is just the tip of the iceberg. This explains what we're striving for. But currently there are a couple of really serious threats to the Medicare system. We're asking for Medicare for all or healthcare for all, but right now the Medicare system is at risk of being privatized, which means that different entities are trying to take it over for profit. So it's a big topic.
Do you folks have any? If folks want to get smarter about this, do you folks offer any workshops or programs on this?
As a matter of fact, we have one coming up. There is Susan Rogers is the immediate past president of Physicians for a National Health Program. She is going to be speaking in Asheville on Thursday, May 11th at the First Congregational Church downtown on Oak Street. So, that will be posted on our website, etc. But, if people want to just kind of bookmark that now, Thursday, May 11th, Susan Rogers, 7 p.m. The First Congregational Church on Oak Street. Thank you for.
And do me a favor. I'll ask you to do me a favor if you can. And you have my email address. Send me information on that because I'll publish. I have a blog and some other things. I'll publicize it in. But such a great topic.
Terrific.
But I'll kind of and there's no answer to the question I'll raise, I guess. But how do we get and you've made a convert of me, thank you. But I sort of was there anyway. But how do we get this out of being just a societal issue as opposed to a political issue? How do we it's like
a great question.
But it's such a real problem because there's so many aspects of this. As you're saying, the hospitals, the doctors, the patients, but then a lot of it's tied into politics, and it's I give you folks so much credit for trying to get this off the ground, but it's like there's so many ways, where do you go first, So how does it become a societal issue everybody buys into as opposed to a political issue?
Well, I've joined a group called Pro Social, who has a motto, let's make the world better for everyone.
Okay.
And I think the strategy is appealing to a local community to say, how could we make Asheville better for everybody? And I think it's really tough because we are quite absorbed in the political conflict about it. But I think you've really very wisely brought up another whole piece, which sort of is the visionary, the societal, cultural thing. And is this the city we want to live in, where we don't have healthcare for everyone?
Yeah, and actually, so interestingly enough, we have a proclamation from the city of Asheville.
Nice.
From 2019. What we now want is a resolution from the city of Asheville. There are Medicare for All resolutions. It's an organization that's national, and cities like St. Louis, in North Carolina, Orange County, I believe Durham, and there's at least one other place in North Carolina. No, I don't think so. But have made resolutions for it. And what that means is that they're willing to stand up and be notified, and state that they stand behind this. Doesn't mean that they legislate anything or they set monies aside for it. We've collected about 400 signatures thus far to bring both to the city and the county to ask them to resolve for this. Yeah.
Is there any place in the country now that has this? In other words, it's like, it reminds me of, well, this reminds me a little bit of the movement in Asheville, a living wage, which is a cool concept, that
Right.
people have a living
Right.
wage. Are there
Right.
any places that have healthcare for all or Medicare for all?
There is a county in Michigan.
Dunn
Yeah.
County,
Yeah.
and they had a ballot
A referendum, right?
referendum
Right.
that they got passed, and it's a wonderful.
Again, though, political. So it all amounts to, nothing changes unless you change the law.
Right.
So, and that's, and you get through that through politics, but you get to the politicians through money. So now what we have to do is shut off the money flow from the insurance companies and the pharmaceutical companies to the politicians so that they don't have to vote that way.
And the one Marsha just mentioned in Michigan, so is that going to come to fruition or is it happening?
Well, it did. They won.
Right.
They put this
I don't have it
on the ballot, but it was quite a structured approach because they
Right.
had a county commissioner actually introduced it himself to the board, the county commission, and it happened that the night that they introduced it, that they were going to hear the budget hearings for the health and education director. Okay, and so the Medicare for all piece had gone, and then she did hers, and one of the county commissioners said, ask her this question. Now, we just heard this about healthcare coverage for all. Would that have any impact on your budget? And she goes into a state, and of course, it turned out it's a very Republican county. Republicans won their elections, but what do you call it? It's a
resolution.
The resolution won by 9%.
The referendum.
Referendum. They went 9% over. So
we don't know how they're enacting it, though.
Right.
But it did also involve doing a lot of grassroots, going around to people and knocking on doors and saying, because what we were doing was getting individuals to vote for this idea that people should have Medicare for all, just like we vote for ideas that we should have clean water.
Right.
And white paths. So that I think the referendum approach is actually
Has merit.
Do you think we'll ever see it in Asheville?
Possibly, yes.
So the Reparations Commission in
I was going to say, it reminds me of it. Right.
Yeah. So we have, there are a few members, one in particular who has been very diligent. Thank you. Very diligent about attending all of the meetings for the Reparations Commission that have to do with health, and has introduced our resolution to them just so that they understand what we're looking for. So I think that by working in tandem with groups that have traditionally not had access, parity, whatever we want to call it, equity, that's another way that potentially we can look to achieve this.
One beautiful story you should know is Medicare was responsible for integrating all of the hospitals in this country in 1 year. Johnson got on a high horse and said, we're not going to give those hospitals Medicare dollars unless they integrate their facilities. Wow. And this was back in '65, and there were a lot of facilities that needed to be integrated. And no one thought it was possible that he could do it. But it's the one system in our country that is truly integrated.
Interesting.
Our hospitals.
Anyway, I'd like to thank you both for being my guests on this Blaine's World podcast. If I can ask you one last time, Dr. Ellen, Dr. Marsha, if folks want to get more information about the cool stuff you're doing, HealthCare For All, WNC, or you name it, what would you say is the first thing they should look at?
So the website, HealthCare For All WNC, all one glom together thing, .org. HealthCare For All WNC.org. We do have a Facebook page, HealthCare For All WNC, and Physicians for National Health Program, PNHP.org.
And Mrs. Dr. Susan Rogers is coming.
And Susan Rogers will be here on May 11th.
And again, get to the May 11th session. And again, if you
Yes,
send me
that would be
information,
very good.
I will do that.
send me information, I'll get word about that. I'd like to thank you guys both for
Thank you.
opening my eyes, but thank you very much. I want to say
Welcome.
goodbye to you, but I think I'll be able to stay with you a second after we sign off. So thanks
Okay.
very much for being my guest.
You're welcome.
You're welcome.
Thank you.
Great.